Hi, everyone. Welcome to today's session, Leadership Playbook, an international perspective of essential competencies for health system executives post-COVID-19. This session is co-hosted by the Commission on Accreditation of Healthcare Management Education and the International Hospital Federation. And now, let me welcome our two hosts, Anthony Stanowski, President and CEO of the Commission on Accreditation of Healthcare Management Education, and Ronald Lavender, Chief Executive Officer of the International Hospital Federation. Anthony and Ron, can you provide me some backgrounds on your organizations?
Hey, thanks everyone for joining us today. CAHME is the Commission on Accreditation of Healthcare Management Education, and our mission is to serve the public interest by advancing the quality of healthcare management education globally. And we do this in 4 ways. One of them is we set measurable criteria for excellent healthcare management education. The second way is we support, assist, and advise programs who want to seek or meet the criteria of CAHME accreditation and in a process of continuous quality improvement. The third approach is by accrediting graduate programs that meet or exceed the criteria. And the fourth way that we meet our mission is by making this information easily available and readily available to everyone, interested constituencies, including our stakeholders, our employers, programs, students, all on our website. Ron?
Thank you, Anthony, and welcome everyone. I'm calling you coming in from Geneva, Switzerland. And the International Hospital Federation's vision is a world of healthy communities run by well-managed hospitals and health systems where individuals can reach their highest potential for health. And I won't read you the mission. You can see the 6 down there, but one I would like to highlight is that we're about sharing our knowledge and expertise and bringing people together. And this is a great example of the IHF and CAHME working together to do a knowledge exchange. And then our 2 speakers here are really helping us out. So welcome, everyone. So let me give a little bit background about CAHME's partners. You can see from the chart, one on the left is CAHME, and the one on the right is the International Hospital Federation. And you can see these really wonderful partners that both of our organizations have. CAHME has 129 health management programs accredited, and IHF has an organization of over 100 different partners across the globe. And you can see on both pages some of the logos from them.
So today, what we're going to do is focus on competencies in healthcare leadership. And briefly, there are several different competency models used by healthcare management education programs as they go about to become accredited by CAHME. Competency models are foundational to the CAHME accreditation process. So programs are allowed to adopt a competency model depending on their targeted students and the focus of their program, the targeted students and the focus of their program. CAHME accredits programs based on meeting criteria and standards that we've established, but also we examine the extent to which they successfully educate programs based on the competency model that they've chosen. So programs are allowed to choose or adopt the competency model that they feel best meets the needs of their students and the vision that they want to accomplish. So in current accredited programs, about 40% of them use the National Center for Healthcare Leadership model, and 60% use a variety of other different models that exist today. As CAHME grows globally, we feel that the International Hospital Federation model is a significant model for programs to look to. So Ron, could you tell us a little bit about the IHF model?
Yeah, thank you, Anthony. So we've went on this journey over 8 years ago of partnering with 18 organizations national, so some in the United States, and then of course international bodies across the globe. And we created a global consortium of healthcare management professionals. And we came up with really 4 goals for this consortium. The first is the competency framework, which we'll talk about later today. The second is the professionalization, enhancing the professionalization of healthcare management across the globe. To my colleagues in the United States, this has been around for decades, but this is not necessarily the norm across the globe. The third goal was to really promote education, continuing professional development in our networks. And the fourth goal is to really advocate that hospital leaders, healthcare managers, have a vital role to play in clinical quality and patient safety. And those are the 4 goals that we outlined for the consortium. If you look at some of the work that we've done more recently, we've taken this work and we've put it into a global competency directory for healthcare management. So what does that mean? Well, working with our partners, we came up with 5 domains, 27 subdomains, and 80 competencies. We relied heavily on the Healthcare Leadership Alliance competency directory, and then we really did some mapping to see how professional healthcare leaders work within these 5 main domains. We try to make sure that the competency framework was flexible and could be adapted to local settings, i.e. different countries, different cultures around the globe. So what do we have today, which anybody can access, is that we have an online self-assessment tool of these competencies. It's really a kind of a neat tool that I would encourage everyone to take a look at. We developed it in 7 different languages. It's free for anyone to access. And you can really do a self-assessment and look at your competency as a manager with your career path, where your strengths and weaknesses are, and how you compare with peers across the globe. So as more and more healthcare managers take the assessment, better and better the data source is for comparison. We have over 1,000 healthcare leaders that have taken it, and our goal is to continue to grow that database so we have a really good comparison tool.
Ron, thanks for that interview. I think that competency model and the assessment is an incredible resource for healthcare professionals around the globe. What we're going to look at today is a survey that we did that examined the impact of COVID-19 on healthcare management education, and really the impact focusing on how the competencies were related and were impacted and became more valuable among healthcare professionals. So what we've done is we've assembled 2 great experts from around the globe. Curt Hohman, a Senior Vice President at Avera McKenna in South Dakota in the United States, and Carlos Mur, the Director of the CAT Barcelona clinics in Barcelona, Spain. And these 2 folks are going to give us perspectives on how competencies became emphasized in certain areas and really were important in their management of facilities. So the first thing we're going to do is ask Carlos and Curt to just introduce themselves quickly, and then we'll get into the presentation. So Curt, first I'll turn to you.
Thank you, Anthony. Yes, my name is Curt Hohman, and I'm the incoming board chair for CAHME and fill the sponsored board member seat of the American Hospital Association. I'm the Senior Vice President of Managed Facilities, as Anthony said, for Avera. And for the past 24 years, I've been responsible for the operations of 24 rural hospitals in towns ranging from a population of 800 to 12,000 people. Because these communities are separated by many miles of farmland, I've learned to lead remotely before pandemic made it the popular thing to do. So I look forward to speaking with you today about that topic. I earned a bachelor's degree from the University of South Dakota and a master's in health administration from CAHME accredited University of Missouri.
Well, thank you, Curt. Carlos?
Yes, thank you very much, Anthony, and good afternoon or good morning, everybody, for several reasons. Okay, my name is Dr. Carlos Mur, and I became the director of CAT Barcelona clinics here in Barcelona, in Spain. In October 2020, we dedicate to mental health and addictions, and we have 4 different centers in Barcelona and the neighborhood area. I have been a member of the National Board of Directors of SEDISA, the Spanish Association of Hospital Managers, since 2016. Prior to joining my position nowadays, I have worked as a consultant in psychiatry for a few years in Madrid, as managing director of the Psychiatric Institute Hospital in Leganés in south of Madrid for 3 years, and as the general director and CEO of the Hospital University of Fuenlabrada, also in south of Madrid, for 5 years. And moreover, I've been the scientific coordinator of the Spanish mental health strategy for the Ministry of Health and general director of social health coordination in the community of Madrid. Well, I have a bachelor and doctor of medicine and surgery for the University of Zaragoza. I'm a specialist in psychiatry. I have a master's degrees in legal and forensic psychiatry and psychotherapy and healthcare management. And I'm a fellow in psychosomatics and lesion psychiatry from Mount Sinai Hospital in New York City in the US. And I am International Distinguished Fellow of the APA since 2015. And nowadays I'm fully dedicated in SEDISA in Spain in order to validate the essential competencies for health system executives. And I'm also in charge of the International Relationship for our Society.
Thanks, Carlos. So what we did is we created this survey, and in partnership with the International Hospital Federation, the European Health Management Association, and the Association of University Programs and Health Administration, we surveyed healthcare management educators from around the globe. We received 229 responses representing 150 universities and 21 different countries. Now look, this isn't a fully scientific survey, but it really is a broad approach to understand how academics viewed COVID-19's impact on the education of healthcare administration and leadership management from around the globe. So one of the core questions that was asked, and it was a very short survey, one of the core questions that asked was, what was the most important competency domain that the educators felt was essential during COVID-19? And when you look at the results that kind of came up, when people said what was the most essential competencies, it related to critical thinking and analysis, leadership management, and communications. And those 3 were really intertwined in a lot of different ways. Community engagement and innovation also kind of came up, and then a variety of different others fell in the other category that people selected. But what I want to look at next is communications. And I think Curt and I had, Curt and the team really had an interesting discussion around communications and the role that kind of played as within Avera McKenna. So Curt, I'll turn it over to you next.
Great, thank you, Anthony. Well, we all know that healthcare is based on relationships between patients and caregivers and managers who lead those caregivers. And the foundation of those relationships has always been based on face-to-face connections. We all know that COVID-19 caused a break in those connections, and we're all forced to create new ways to connect to each other. I just want to take a few minutes and share with you what the research says and what my experience has taught me about how to be successful in communicating, managing, and leading individuals and teams who are physically distanced from one another. In essence, how to make the movement from a physical workplace to a remote or virtual workplace. To accomplish this, I'll discuss the challenges of managing employees virtually, the competencies needed in this setting, and tools to use to overcome those challenges. As you've heard from my background, I have many years of working with geographically dispersed network of small rural hospitals around the city of Sioux Falls in the state of South Dakota. The hospital system I work for provides essential administrative and clinical services to those hospitals that are too small to provide these services themselves. In an effort to understand what services are needed, I would often travel 2 or more hours 2 times a month to stay in communication with leaders of these organizations that reported to me. As a result, I was traveling 35,000 miles or over 56,000 kilometers every year. That's going from New York to Los Angeles, not once, but 12 times each year. As the network of hospitals grew, this method of staying in contact became inefficient and really impractical. So beginning in 2016, using the telemedicine technology that our system already had in place, I began holding video conference meetings with my team and the teams at the smaller hospitals. I also held individual meetings with the CEOs at these facilities as well. While this saved travel time, there were a number of unexpected barriers to good communication and overall management that occurred along the way. With changes, we were able to create improved communications between the teams and for those who reported to me. As we begin to think about communication from a traditional office workspace model to remote work, we need to think about what is different and make adjustments from there. So now think of yourself as the manager. What are we missing as a remote manager compared to when your employees were working in the same workspace? First of all, losing the visual aspect of seeing employees also means losing the ability to provide day-to-day guidance. We also lose an understanding of their personality characteristics and their leadership style. Who are they as a person and their motivations, as well as to getting to know other members of the team. Now think about the employee. What is missing for them as a remote employee? Let's see, what is missing for them? The culture or expected behaviors of the organization. There's also the informal, unwritten culture of the organization, something that I refer to as just how work gets done. Values of the organizations and the values of the leader are much more difficult to detect remotely. Without the benefit of the workplace, remote employees may not know the key leaders of the organization and what resources they can provide, as well as those with informal power and influence as well. Also missing are those unofficial or unplanned meetings, such as in the hallway or happening before a meeting. And finally, relationships with peers and seeing how they get things done. It's just an interesting way how we, working side by side with people, we really understand how an organization operates and how things move forward. So now, moving to the next slide, let's consider communication itself. You're all likely familiar with what the research says. Communication is the following. First of all, 7% is words that are spoken. I took the example of Dr. Spock from Star Trek, who would speak with an objective monotone. His communication was limited to only the spoken word. 38% is tone or inflection of the words. Now, we couldn't understand what R2-D2 was saying, but how he said it was readily apparent. But the majority of communication, 55%, is body language. Now, I don't know what this little girl said, but her body language and expression certainly says enough. This research demonstrates that while it's very important to use good audio in remote meetings, only through the use of video will each person be able to process all aspects of communication. Now, I understand some people don't like to see themselves on video or be seen on video. Maybe it's because they're just not being completely dressed like we see in these YouTube videos sometimes. But having the ability to read your employees' nonverbal cues and be aware of your own is important and will aid in understanding completely what is being communicated. Another point about using video It may help prevent all of us from multitasking. American researcher Dan Heath has concluded that the human brain does not actually have the capability of multitasking. Maybe something that you're doing right now, I don't know, such as reviewing emails or listening while we're listening to someone else speak. So I encourage you not to multitask. It's easily detected, and others in the meeting will know when you're not paying attention. You know how that is, where someone gets called out. Oh, could you repeat that question? That person may have been multitasking at the time. So now let's switch the discussion to what we are missing when working with remote employees and how we can regain what is lost. The first place to start is understanding a person at their fundamental level and that they know you in the same way. Recall the ancient Greek maxim popularized by Socrates, know thyself. Our modern terms for know thyself is emotional intelligence or self-awareness. But how can we accomplish this? We like to think we can assess ourselves with these personality traits, but we do have biases that do get in the way. That is why I found that it's a reliable and valuable tool to measure personality traits or leadership tendencies is through a tool such as DISC or Myers-Briggs, as they are more accurate and offer greater insight in their findings about ourselves than maybe a self-assessment could do. By understanding our styles, which includes strengths and shortcomings or blind spots, communication really can be improved. It's equally important that I understand the characteristics of those who report to me. So not only knowing yours, but also those you report to, understanding what their personality traits are. Now let's switch to what are our values. I've heard it said that I can understand what your values are by knowing first how you spend your time and how you spend your money. These simply represent priorities in our lives and can be a strong indicator of our values. Now, how do we put this into practice? When we work together in the workplace, what would happen before meetings started? Well, we'd have small talk before and after meetings. Topics would come up, such as what did you do last weekend, or remind me what's your child's name and age again. Other things that you really learned about people and what their priorities and values were. These interactions simply don't happen as a matter of routine in remote meetings. However, these informal communications represent positive maintenance of a relationship. If the meeting does not have too many attendees, and particularly if the meeting is a one-on-one, I would encourage you to take 5 minutes to have these kinds of informal discussions. It shows you care about them as a person, not just as a worker or employee. Again, this person is probably working in their home. They're obviously the only employee in their setting. So sometimes reaching out and again, having that good maintenance of a relationship is important and is valued. It shows you care about them, again, as a person, not just as an employee or a worker. Also, the relationship cannot be a one-way street. You need to let yourself as a leader be vulnerable as well. Now, in groups, that's a different dynamic, obviously. Maybe consider using an icebreaker as a means of getting to know each other. This could be a question that reveals something about each person. Now, oftentimes, we don't want people to get too personal, but usually people will just be as comfortable as they want to be in sharing how much they want to about themselves. It could be something very neutral, like just tell me about your first job. What did you have? Sometimes kind of interesting to hear about what their background is, or maybe something a little more in depth, like tell us something positive about what you learned about yourself during COVID. We've had discussions like that, and it's very revealing about kind of what people went through. So I just want to take an aside here about accessibility is so important and it's so missing in the remote setting. I'm talking about those hallway conversations that often happen in the physical workplace. Scheduled meetings are great, but remember those quick hallway conversations where you're able to get some brief but important direction from your leader. How can we replicate those remotely? Something I've instituted with my team members is providing them with an invitation to have a quick conversation. I do this by saying, just text me a text message saying, do you have a minute? I have a quick question, something like that. I make every attempt to get back within an hour. And these really can help replace those quick hallway or break room conversations that are important, that some people just need to be able to move forward. Let's move to the next slide. How can we motivate employees remotely? A question to ask maybe, how did you motivate them before COVID? I want to briefly refer to Daniel Goleman's has research that found 6 ways to use power as a leader, which in turn are methods to motivate someone who reports to you. These 6 methods were further divided 2 ways, with methods that cause dissonance, or those that create feelings of conflict, and those that create resonance or feelings of harmony. Now, each motivational style can be successful in a given situation. We all know that. But when we consider generational expectations for leaders, competition for employees, and the corresponding need for a satisfied work life, the 2 methods on the left should be used sparingly and with great emphasis on the 4 methods to the right. I found this to be especially true with remote employees. Unless you can objectively measure output and quality of their work, there's an inherent level of trust that must be given to remote employees. And this trust, just for my experience, has been incongruent with leadership methods of commanding and pace setting. Now I want to finally go to kind of that special challenge of new employees. And this slide will also kind of provide a summary of what we've been talking about. At the most fundamental level, understanding the organizational culture and strategic plan is a necessity. The many implied communications of the workplace simply cannot occur as a remote employee. So we need to make those implicit explicit. Consider an onboarding program specific for remote employees. This is more than just a one-day orientation. An onboarding process that uses some on-site and some remote-friendly video recordings has been very helpful in my organization. We highly engage with new employees through multiple texts and phone calls in the days leading up to their first day on the job, and then make sure to make contact with them repeatedly immediately after starting. You know, as a new employee, just those first few days is a challenge, and having someone, having those touches, I think has been very helpful for us. We've seen our first year turnover decrease tremendously. Next, there's an amazing amount of informal rules, norms, and expectations that a formal onboarding process just can't achieve. We found that setting up mentorship relationships with new employees is a successful way for new employees to understand what is often not stated within our culture. And by the way, as your manager, I would encourage you not to be their mentor. You have a role as their leader, and that just doesn't work as well, what we found being the mentor. So instead, considering a mentor to be maybe a trusted peer of yours that you've worked with, or maybe a peer of your employee. Instead, this may help with communicating what the organization's culture and values are, both formally, but also importantly, informally. Mentors can help new employees more quickly and effectively understand how to be successful. Communication and building a relationship is particularly difficult with new employees. We all know that. Again, understanding each other's personality traits is key to new employees. This lack of understanding is often why we hear an employee say, unfortunately, in their exit interview, you know, I just didn't click with my boss. That just is an indication of a lack of kind of understanding of motivations of each other. Again, understanding how the new employee is motivated. What does that employee expect from me as their leader? What should I expect from them? Again, DISC and Myers-Briggs can really help answer these questions, or at least navigate how the employee will most be open to those kinds of communications. Lastly, in the office, those 2-minute conversations that help new and veteran employees with a problem, or simply to answer a quick question. I invite employees to text me if they do have that quick question. It's just a way to replace those informal hallway meetings and provide timely direction and guidance. So in summary, we take for granted how much information is exchanged in the workplace environment. When employees physically work together or an employee sees their manager routinely, valuable relationships are created really without even trying. In this setting, we can more easily understand each other and our personality traits. Workplace employees pick up on cultural norms and values as they are experienced and communicated in a number of different ways. These are all important as they help us understand what is our role and how we are to carry out that role. The challenge for us as leaders is replacing these communications and interactions in the remote setting to understand what is lost and how it can be regained remotely. So I hope that I've either validated some of the things you've implemented already, or maybe provided you some new tools or ideas to recreate the positive aspects of the workplace and translate that into the remote workspace. Thank you for your time and attention.
Thank you, Curt. What a great discussion with lots of good information. And though it was labeled about communication, you can see on the slide here on the screen, this is the slide that Anthony shared in the beginning, which are some of the results from the survey, 229 respondents around the globe, that communication as a dominant competency during the pandemic was 15%. But I think you would agree that it's really communication and leadership combined, because what you are talking about is how you as a leader manage and lead using communication and good communication. So it's good to see the results of how the pandemic or the influence of the pandemic on our competencies. I would like to turn over to Carlos, who's done a lot of work with the International Hospital Federation over the years around competency. And he has some really interesting findings from some of the work that he has done in Spain and his colleagues, also around the competency discussion with COVID as a mix in that. So let me turn it over to Dr. Mur to lead us in the next part of the discussion. Thank you.
Thank you very much, Ron. Hi, everybody again. Well, it will be very brief going into a certain preview, because I would really begin to say that it's been quite a long time ago when we began to do a global work to kind of professionalize the healthcare management workforce worldwide, right? First of all, identifying the competencies, the essential competencies for effective leadership, and they're moreover to have an advocacy for the use and education and training programs for healthcare leaders. We really have been watching how a brand new leadership is a brand new open necessity, and probably the COVID-19 pandemic has really reassured our needs in that field. If we go to the next slide at this point, we can really realize that the IHF has led already an effort to advocate for that professionalization of healthcare management. And we need to acknowledge that this effort has always been critical, because unfortunately the decision makers, the political leaders in many countries do not believe that a professional healthcare management field is important nor necessary. And I think, as a starting point, as a key point, the international framework for collaboration with healthcare leaders and professionals association developed by International Hospital Federation since 2015 has been really a clue thing in that time. And I think that dictionary of core competencies and healthcare leaders should possess has been a good starting point for the amazing work that has been led in Spain and some other countries. I would like to share with you the main findings in the next slide we had about the main competencies identified in our National Congress or annual meeting in the Spanish Healthcare Managers Association, right? And there is something we've been talking about. And if you realize, the coronavirus just has been a clue reminder of how a healthcare executive should be at this point. And I will have headlined the leadership in communication and relationship management, the social and professional responsibility, the interpersonal communication qualities and relationship management. This is amazing. And of course, the professionalism. I mean, the knowledge is quite essential because we are living in a very changing world, and the changing pace is amazingly quicker and faster than it used to be. So we need to get adapted to that healthcare environment and to our organizations. Furthermore, we really identified that the evidence-informed decision-making, operations, administration, and research management was a key competence also identified. Another two very important points which have been previously mentioned were how we can enable and manage change, and how we could develop a decent self-management and resilience. And I would like to headline that one after what the COVID-19 pandemic just has brought to us. Another competence really identified in that work was how we need to be really deep in the systems thinking, leadership, and communication, and developing emotional intelligence and leadership in team-based organizations. How to develop also a kind of political, in a good way, leadership. How to bring up and to build and lead interdisciplinary teams in a collaborative leadership. And leadership is much more than a mandatory way of doing things. And of course, that a truly hierarchical field is no longer attractive to a lot of very nice and very, very powerful healthcare managers. And of course, we can't do anything without the ethics and the professionalism leading that change. And of course, how to lead the change of leadership, the organizational learning and developing, and how we deal with the talent we have in our organization was another main competence basically headlined in what we did in Spain. So we basically built what we call the healthcare manager's profile. How someone who gets really interested in becoming a healthcare world executive should begin, no matter how his or her background is, if it comes or she comes from a medical background or for the economical management. But of course, that intelligence, scientist's capacity, motivation for change, communication skills, psychological tools, listening abilities, the spirit of observation, to develop command and leadership skills, hard working capacity, maybe I should say really hard working capacity, a kind of an inconformist approach, and that so-called perseverance and resilience will be very necessary in these troubled and turmoil days we're living. So we'll basically build, and we're going to which in the next slide is, so what is the role of a healthcare manager? We're working on that in Spain in our association 2019. And obviously, there were a lot of studies which began to associate the role of the manager with the healthcare outcomes, which was really powerful. Our anthem in Spain is that a good managing also saves lives, because there's something else that needs to be taken into account. But in the end, it really sums up the efforts of a lot of people. And finally, it provides good health results in the patients we're treating. And it's true that the influence of the boss and managers on the worker, the role of leadership, the way of directing and coordinating, the consistency of the manager actions with the values, trustworthiness, sincerity, transparency, the courage and the clarity of ideas, and of course, the obligation to take care of the workers, to worry about their development, personal and professional, their future, their jobs, and their health, was something which was tremendously and tragically headlined by the COVID-19 pandemic. And I wanted to provide you a brief example of a randomized study which was conducted in Britain in the National Health Service from 2005 to 2015, in which basically it arrived to the conclusion that how transforming leadership helped to reduce brain vascular diseases 30-day post-discharge mortality rates in more than 35 general hospitals in the United Kingdom. So I think this is a very powerful idea, that the way we change things and the movements we do really provides a key point for the manager roles according to the health results we're basically recovering afterwards. So we go to the next slide. We will really headline that, and I wanted to provide you the reference from the Nursing Research magazine, which was published in 2010. So when we were really studying those competencies and this kind of leadership we wanted to develop, obviously we knew that if the new competency model was useful for something is because it really led us to develop a new health system based in value, not in processes and not in any other things we were measuring. So value, according to Michael Porter definition so many years ago, has really changed, and it depends of the person's point of view. Value could mean something very different to healthcare executives, to clinical professionals, to patients advocacies, relatives, and of course to associations and patients representatives. But obviously, this competency model that is being developed worldwide is the first step to develop what we call the value care health system, which is something really revolutionary, and what I think it still will take some years to be completely real in the field. But it's true that there are 5 steps toward that high value care, which was pretty good defined in early 2020. First, to understand the benefits, harms, and relative costs of intervention that you are considering. Second, decrease or eliminate the use of interventions that provide no benefits, 0 benefits, and even may be harmful in terms of side effects to patients. Always thinking of those MRIs prescribed for patients that they really didn't need it at all. And of course, we are providing some radiation to patients, apart from improving not expenses, I could say the waste spending that is such a problem worldwide. The 4th step will be to customize a care plan with a patient that incorporates their values and addresses the concerns, right? We need to really put the patient on the center. And of course, the 5th one could be to identify the system and at some level opportunities to improve outcomes, minimize harms, and reduce the healthcare waste, which consistently means about 15 or 18% of the annual budget of most of the hospitals worldwide, which is quite a lot. So we're really working on that professionalism track. And unfortunately, as all of us will remember, in early March 2020 in Europe and America, but a little bit before in Italy, and of course, in late December 2019 in a city which the name will be always unforgettable for all of us, called Wuhan, well, the earthquake came. And if we go to the next slide, exactly, I would like to express what we were working on Spain from that before COVID really made the intention. We really wanted to validate those international health hospital federation competencies level, and CEDISA and the new Catalan of hospitals here in Barcelona. We wanted to incorporate those competencies as a basis for healthcare management practicum, for hospital-specific training, for future healthcare managers, and for a fellowship program. We have been currently developing the first university bachelor degree in healthcare management in Spain, and of course, there was a lot of content delivered through that. So we were exactly working what kind of competencies really had the greater consensus of all amongst more than 250 persons who really were in the sample of our study, out of a sample of more than 2,100, which we are the associate of cities and nowadays in Spain. And the results were really defined as we have in the next slide, which was basically, okay, how we do validate those reference of different domains and how we really support the accreditation system for the professional development of Spanish health managers we were currently developing. That was the objective. And in the second slide, and the next one, we had that the sample contained, I think this is really remarkable. We wanted the 30% of the sample to be the CEO of the hospitals, where we wanted to listen to what the others had to say. And 40% of them were the economical management directors, 40 were medical directors of several hospitals, and 20 of them were nursing directors. And we designed the sample to be geographically representative of the 17 autonomous communities in Spain to have something consistent in its validity. And the main results I wanted to share with you were basically those ones. The competence with a higher degree of consensus in Spain were related to, well, first of all, how a leader communicate the mission, objectives, and priorities of the organization to internal and external entities. The second one, the problem analysis, promotion of solutions, and encourages decision-making. And the third one, a lot of people talk about the organizational climate, how we should really extend trust, transparency, and how we could focus on the improvement of the services, how to get the teamwork to be encouraged, and how we could support diversity in those teams. The fourth one was the knowledge of assumptions, values, strengths, and limitation, how to present high ethical conduct, transparency, of course, how to develop a compliance with the laws and regulation, quite important, of course, how to use of joint data to assess performances, set targets, how to ensure compliance with the applicable privacy and security requirements. And ninth, last but not least, how to develop and implement quality assurance, satisfaction, and patient safety programs. That's been a key thing developed in Southern Europe now lately. And on the other hand, in the next slide, we have all those competencies where there were the lower degree of consensus. And I really was surprised by the first one, like demonstrate understanding of the role of media and public relations, because it's getting more and more important at these days. How to advocate and participate in the health policy initiatives, how to evaluate critical processes related to public health surveillance and control systems. Believe me, this was just 1 month before the turmoil of the COVID-19 began. Nowadays, no healthcare manager would say that, right? All of us, we could agree that the public health surveillance will be one of the highest priorities we could have. The fourth one was the use of the knowledge of project operations and capital budgeting. I was also surprised by that one, by the way. The fifth, to demonstrate knowledge of government agencies and regulators. We need to work through them, so I think it's also important. To apply knowledge about the theory and dynamics of organizations, to interpret public policies and processes in the organization, and to apply marketing principles. Well, fair enough. So after that, what we see in the next slide is that obviously what the COVID-19 has brought us. Okay, first of all, an amazing wave which really changed it all, which could be discussed for hours in this webinar, and we don't have the time. But when the first wave just start to dissolve in May 2020, even though the turmoil has continued in so many continents, we had an increased pressure in all of our hospitals organization due to the delayed activity united to the previously unattended demand. So if we take it into the best way, it was really an opportunity to develop efficient systems through new healthcare executive competences, because in the past, we knew that the peak of the iceberg, which was over the surface of the water, it was only a brief part of it, maybe 15, 20% of the activity we had to attend. But there was so much under the water, and in which we also need to attend and how to normalize the activity. And we need really to despressurize a little bit the system. Otherwise, the risk of collapse was very close to that. And I think we're still suffering that risk, we could say. So according to the competency model for healthcare executives, what this coronavirus have brought to us? Well, personal challenges, by all means, an amazing and historical change to develop some structural changes for the healthcare system. And as we can see in the next slide, a main problems in the aftermath, right? We had the complication of the pathologies of diagnosis patients, diagnostic delays, the compensation of the treatment of chronic patients, pressure for testing, complication from the interruption of rehabilitation treatments. We have suffered quite a lot with chronic patients. The increased healthcare pressure in the emergency department, and the risk of errors due to staff saturation and accumulation of casualties. And in this point, I will ask for 15, maybe 20 seconds to remember all the task force and all the healthcare workers which really suffered from the pandemic. In some of our hospitals in Madrid, 48% of the professionals were infected by COVID-19, including certain executives. Some of them died, even some executives. 4 medical directors of hospitals in Madrid, they died. And of course, we knew that we're still treating PTSD, burnout syndrome, and a lot of psychological consequence, like in those 3 nurses that have provided me with their portraits to be an example of that. And what about next, right? So next slide, obviously, what have we been through, right, in these unprecedented and irregular times? Well, we need to find, in one hand, solutions for the organization's regular operation, and through an amazing level of uncertainty. In these situations, obviously, managers should provide clear and effective communication with all staff and amongst healthcare teams, infection prevention and cultural training for healthcare facility staff, recommendations for getting and for using in a very rational way the personal protective equipment. Obviously, we also need to assert training to all frontline workers on essential psychosocial care principles, psychological first aid, and how to make referrals when needed. Obviously, we need COVID-19 proper treatment and isolation and quarantine seats, psychosocial support to health workers during the quarantine, and of course, maybe the most important task of all, the responsive communications with citizens when panic has been spread all over, right? And the cooperation and coordination with national and regional epidemiological and infectious disease centers is fundamental in that way. So really, all this competencies model for the healthcare executive has been reinvented in just a few months, right? So we pass to the next slide. What we see is that we had a huge road, a very bright road to be still built. There's a lot of challenges to be faced, but I think if we look optimistically to the future, even those people that are still suffering COVID-19 persistent symptoms from time to time, and I really would like to thank Anthony, Ron, and Cor, and Dan, and all the staff for the patience they have had with me in the latest weeks for that. And I think we're still to ride and to drive on the right side of the road, as Van Morrison used to saying some years ago. And we still really, we're already watching the light at the end of the tunnel. But it's true that if the world, the patient's demand, the healthcare world will never be the same that it was 1.5 years ago. We always need to remember that as the healthcare executives, will no longer be the same anymore. So there's a lot still to be done, but I think this webinar could be quite a starting point. Thank you very much for your attention and time.
Carlos, thank you very much for those comments. It was very emotional, kind of hearing the impact in Spain. And you know, we've heard the same type of things in some of the hospitals up in northern New Jersey and in New York City as well. I think one of the interesting things, and right now, if I can say, anyone who would like to type any questions, type them into the chat room, and then we'll address them. And we did get one question kind of coming through. Someone talked about how the competencies are kind of interlinked together, and you kind of see the connections with those and the importance that they had within because of COVID-19. The question kind of related to, we saw competencies change during COVID-19. The question to the panelist is, how will they change post-COVID-19? Do you think we'll go back to where we were in 2019, 2018? Or do you think we'll take some of the learnings, or how will we take some of the learnings and kind of morph and change the competencies going forward? So let me kind of open that up to the panelists.
Okay, if you want my personal point of view, I think we ought to incorporate a lot of findings and a lot of learning points from the pandemic. So I think those competencies will change. And from the hospital manager's point of view, I think we're already incorporating two things. The very true key importance of the primary care barrier in order to promote health and to prevent certain inputs, and of course the coordination with nursing homes and the social care work, which has really very, very damaged worldwide through the pandemic. We really witnessed an amazing drama in Spain and all over Europe about that. So I think we need to incorporate a lot of competences. And I insist it will be quite the same if we wouldn't do it afterwards.
Yeah, my comment, I think, would be I think what we learned in the pandemic and what needs to be carried forward is, I'll just say frankly, some of our leaders' egos, including mine, of really needing to put that on the shelf and say, okay, infectious disease physicians, tell us, where are we at with the infection right now? Our supply chain people, where can we be getting PPE? Syringes are in low supply. Where are we going to get them? Our employee health nurses, where are our employee health situation? How many are out? How are we going to replace those employees? I think we found, there was kind of this centralized structure when it first came out. It's a crisis. Everybody goes to the top, goes to the leader and say, what do we do? I think I was really appreciative of the leadership that we had to say, okay, we have got experts within our organization. I'm going to defer to them. Now, when we need to come up with a overall strategy, then that's fine. That's, responsibility of top management. But I think there was that recognition of the people that really do some of this specialized work every single day, that we would defer and give them a significant amount of time to help us really plot the course for our 17,000 employees. And I think that really helped, and we need to maintain that because that was very, very helpful.
Curt, I would agree with that, and Carlos the same. One comment on how I think the pandemic is going to affect the leadership or the competency. I think about the people that are choosing their career path right now, and that they have this shared experience of seeing hospital leaders or healthcare leaders in a different light than they've had before. And I truly think that it's going to drive, some really very good, competent, natural leaders into the educational tracks for healthcare leadership, because there's a different emphasis today on being a hospital leader or being a healthcare leader, and the skill sets needed. So I think that we'll see a new crop of folks interested in healthcare leadership, and I'm real excited to see how they evolve because of this natural, this global kind of inflection point for everybody in the industry.
Thanks, Ron.
Anthony.
Okay. I'm
No,
sorry. Thanks, Ron. It's been very interesting because we've actually seen that. We've seen an uptake in admissions into healthcare management education programs as this has become the area where young people feel that they can make a difference and can make an impact in this world. So along with that, we're at 11:57 right now. I'm going to, there's one more question I think would be interesting, and let's get some quick responses from it, and then we'll go to end up. So this came from Eileen Alexander, and Eileen, thanks for your comments. Her question was, how might we integrate these value care competencies with academic courses and programs? And she kind of talked about how the competencies revolve around organizational psychology and profound knowledge promoted by Dr. Deming. So again, how do we integrate these value care competencies with academic courses and programs? And Carlos, you touched on this a little in your presentation. Do you want to take it first?
Okay, no problem. Since we've been talking about how main steps towards the high value care definition will be, I think it's really essential to develop like a post degree with a master in sciences or something, which really could be devoted to healthcare manager, but including the concept of value from the beginning, because we have been focusing on a lot of competencies and things. But I do think that development of management educational whose content delivered through training programs will be centered on value, that could be essential. And by all means, the vast majority of healthcare managers come from the medical world and nursing world, and maybe economists and people who has the degree in law. I think we could really incorporate those knowledges and those teaching points in the degree in medicine. Why not? Because there are not so many things which are learned during that period.
Thanks, Carlos. Okay, well, we're near the top of the hour. Ron, I know there's a special event happening at the International Hospital Federation, the World Hospital Congress. I've had the opportunity to attend several of these during my career. They're phenomenal. Do you want to talk about the current event, particularly coming out of COVID-19?
Yes, just briefly, this is the commercial segment for your lecture today. The commercial is the International Hospital Federation has World Hospital Congress. It's on the 44th year. We were supposed to be in Barcelona, Spain in 2020. We postponed it. So we'll be in Barcelona, Spain 2021 in November. Spain is opening up slowly but surely. So we feel very confident. This will be an in-person Congress with an online option for some of our colleagues that can't travel. But I know Dr. Carlos will be there,
Sure.
as well as many others. And so I hope to see you there. So that's the commercial for this one.
Thanks, Ron. Dana?
Thank you for viewing this special co-hosted session from the Commission on Accreditation of Healthcare Management Education and the International Hospital Federation. To learn more about CAHME, visit www.cahme.org, and to learn more about IHF, visit www.ihf-fih.org.